So this presentation will be on public health programs, and we'll be discussing the public health programs and why would we want to integrate pharmacovigilance into public health programs, who's involved, how would you integrate it, and then we'll finally end up with some of the pharmacovigilance methods that are used in public health programs. So public health programs. So what is public health? There are numbers of definitions, and the definitions range from that have ranged over time. But it includes disease prevention, health promotion, some kind of organized effort, and it's amongst the population as a whole. So the focus is on the entire population and not individual patients and diseases. It involves healthy as well as sick people. And the goal is to reduce morbidity and mortality to major and common diseases. So when you have a public health program, the objective is to promote, protect, and to restore health. And the tools that are used, you can use education, you can do environmental stuff, you focus on nutrition, lifestyle and behavior prevention, and this pharmacotherapy is just one part of several different types of interventions that you use in public health programs. And the strategy is determined by the country. For each country, it's according to what epidemiological, according to the epidemiology or prevalent diseases that occur in the country. So, as the components of public health programs are very wide. So you have education, as I said, environmental modifications, nutrition interventions, lifestyle behavioral, preventative measures, screening, pharmacotherapy. It's just one aspect of several different types. Okay, so public health programs. So can you think of a public health program that are introduced into your program, into your country, and what conditions are they used for? Can anyone tell me anything that's yes?
Public health program for malaria.
For malaria.
Another one for tuberculosis and one for HIV.
Okay, yes, that's in Sudan.
Yeah, in Sudan. Oh, sorry, I'm Habab from Sudan.
Anything else? Yes. Smoking. Yes. Yes.
Okay, we have HIV, TB, malaria, and immunization as well in South Africa.
Yes. Okay. So. Yeah. Yeah. So I mean, it depends on different countries and what kind of health diseases and what that are occurring in the country. And so I did a little bit of research before, and just looking at TB, I found that there were some international funds for some of the countries here, and malaria as well. Some of the countries, I think I actually found some in Saudi Arabia, but it's government funded for malaria. I was a bit, is that correct? Yes, and then, and also, yeah, so South Africa, Sudan for malaria. So I just did a little bit of research before to see. And then I was also looking at the people where funding comes from for some of these programs. And I found for Ethiopia, you had some funding came from Global Funds and USAID. For Ghana, the same. And Sudan, you had some global fund, some of the funding that comes for them. So this is just a list of different public health programs that are, so you have tobacco there, and then you have some other, and there are several different ones. Not all of them have pharmacotherapy as an intervention. There are other methods, as I said. So if we look at pharmacotherapy, so public health programs and medicinal products, so when we look at PV, what we want to do when we have these medicines, what we want to do is to identify the risks so that we can inform people so that you have, you know what to expect. So it's also providing, the PV actually provides information to people, that way people feel safer, and then also to minimize harm. So if you can have certain interventions or to minimize, so if you know if a certain population needs to be monitored more closely, you would do that. Okay, so we're going back into the as we discussed earlier, there is accelerated access to medicinal products for priority diseases, for example, in TB and bedaquiline and zelemolide. Medicines are more accessible now due to there are more funds for medicines, and also for there's PQ of medicines, so it's more medicines are more available, and so there's a larger scale up. So the situation at the moment is also some countries do any of the countries here have mass distribution of medicines? You have? Yes. So yes, I think in Ethiopia you have for neglected tropical diseases, don't you? Yes. So you have so in current situation in some countries you have mass distribution of medicines. So you have many healthy, and the population may consist of people who are healthy, who are getting this medicine to prevent, and people who are also may have the disease, because you can't identify if, for example, in certain diseases like when you have worms, you can't identify everyone, so you give the whole population. And so with these disease programs, what you have is that there are good records of the treatment. So these programs are taking very good records of how many medicines they're giving out and what the outcomes are. They're good at surveillance on okay, is the disease going down in prevalence and so on. But they don't pay so much attention, or they don't have that much of a record of ADRs, of adverse drug reactions. And then, so in most settings, PV and PHP operate in isolation. So you have the public health programs, they're doing their own thing, and the PV are doing their own thing. And they're not integrating together. And so if you look at pharmacovigilance, I mean, these are some of the disease programs that we, as our department, we interact with all the time. So HIV, NTD, neglected tropical diseases, TB, and malaria. And so pharmacovigilance can be for all of them. So why do we need to integrate? So yeah, why do we need to integrate? Okay, so sometimes you have old medicines, but you're giving them in a different population. So sometimes the medicines we already know about, but you're giving it to, say, I don't know, maybe pregnant people or children that you don't have that much information about. So you need to know if it's safe in that population. By integrating PV, there is experience of it. It actually increases the public trust in a program, because these programs are very sensitive. If a rumor breaks out, it can destroy the whole program. So you need the public to trust the program, and by having PV in it, they will they know that the safety of these medicines that they're giving, or they're giving their children, is being monitored. Information collected can be provided to public to increase compliance. So by telling people what to expect, it can help with their compliance.
Can we? Noha, we have a question here.
Yeah.
So this was about what you said about outcomes, that you have results on them, but then you also said you don't actually know how many people are sick. So,
well, I mean, you don't know when you're giving the mass drug administration. You know what the population is, but you don't know who of them are sick and who's not. Someone might be carrying the disease, but you don't know. And it's too difficult to, it's just too much time. You have millions of people to distinguish and say, okay, you're going to be treated because you have the disease, and you're not because you don't. So you give it in masses, but you have an idea of the prevalence of the disease within the population. That's different. But individually, you can't say you've got the disease and you haven't. So you just give it to everyone.
No, I get that. So it's just, if you have a good idea of the prevalence, it doesn't really matter, because then the outcomes can be regarded in that context, I guess.
Okay.
Yeah, that
Yeah.
was the question.
Yeah, I mean, generally the disease programs are very good at keeping records of the prevalence. So but what they're not good at is looking at the adverse drug reactions. They don't have good records of that. So So the disease programs, they work in isolate, most of them, unfortunately, but there are some examples of where they do integrate with the PV national centres, but most of them, or in the past, they've been working in isolation. So they haven't really, when they take measurements and they take surveillance, what they look at is the outcome, and they look at how much of the medicine is being given, but they tend to neglect the safety, or collecting information about the safety. Okay, so that by integration of PV into the public health programs, you can help strengthen also the existing national PV system, which provides leverage for setting up a PV system where it doesn't exist. So you can have a public health program, and you may have PV, but it's not as advanced or as established. But by working together, you can actually strengthen that PV center, and then it can help them do other adverse drug reactions for other diseases and in general. Okay, so this is an example of neglected tropical diseases. So the medicines that are used are very old. They've been around for ages. So why would we be monitoring its safety? But it's still good so that you can show that you have evidence to show, okay, we've given it to this many people, and this is how many, and we are monitoring the adverse drug reactions, and this is and we get what we expect to get. There's nothing unexpected, and that will help build confidence in the program. So by doing that, it allows them to continue doing the benefit risk harm. It supports individual benefit harm assessments, promotes public confidence. It can also detect problems of misuse or gaps in training, programmatic errors, and it's an opportunity to educate staff in public health programs on PV. Okay, so again, this is a slide that we used earlier about the introduction of new products. So we have in the pipeline, we have over 300 products for diseases such as neglected tropical diseases, HIV, TB, and malaria. And then most of them are launched in countries where PV setting isn't as advanced. So there's an urgent need for synergistic collaboration. So these are some of the examples that the PV centres have to offer, or good things that they have to offer. So the PV centres, they can detect, evaluate, and prevent adverse events. They have good expertise and capacity. They're independent, and they have spontaneous reporting. So they have, but they have no or little funds. And with the spontaneous reporting, they don't have a denominator, so they don't have the number of the usage of the drug. Whereas in public health programs, they offer a cohort of patients under control conditions, but they don't usually have PV capacity. They have finances, so they're well resourced, and they do PV on their own, but there is a conflict of interest because it's their medicines, and then they're monitoring the safety. It's better to have the safety to be monitored independently. So if I put all those into this, so this is the public health program, and all the darker colors are the good things, and the lighter colors are the negative things. And then if I do the same with the pharmacovigilance, the good things and the negative things are in the lighter color. So there's no denominator is the negative thing, but I think it's not very aligned on it's aligned on my presentation, but it's not here. If I put them together, the negative things are cancelled out. So what the public health programs have, and the PV centres don't have, it makes up. So by integrating them together, you're getting rid of the negative things, and you're sharing all the resources and the positive things. So PV and public programs, health programs. So PV is a requirement for many disease programs, for example in TB, now that you have these new drugs that have early access, many countries are regulators are saying that you have to have PV in place for us to have this drug available in our country. An example of this here is also for seasonal malaria chemoprevention. There was a recommendation by the WHO to have seasonal malaria chemoprevention, which is basically you're giving children some malaria chemoprevention in millions, and it's a recommendation. And in order for what they do recommend is that the pharmacovigilance should be strengthened where it exists and should be instituted where it does not. So they're saying, okay, yes, we recommend this treatment, but you need to have a PV system to monitor its safety. This is an example of public health programs that use PV as that PV was an entry point. The public health program was an entry point for PV. For example, malaria program in Sierra Leone. They started the program itself started collecting information on ADRs in 2005, and that was an initiative because there were a few SF medications during the malaria recommendations, after the malaria recommendations, and so they put a PV system in place, and then from that strengthened on the PV system that was then strengthened, then it joined the program, and then now there's PV in not just malaria, in many other disease programs, that they have a strong PV presence. And it continues to integrate PV and malaria with malaria health, public health programs, and also other public health programs. So this is an example of how a disease program can be used to start PV. Okay, so who's involved? In a public health setting, so who's involved? Who are the stakeholders? Can anyone think of any stakeholders? Yes. So Ministry of Health, healthcare centers.
And you have Ministry of Health, healthcare centers, you have healthcare providers as well. And patients can be also the stakeholders in it.
Okay. Prescribers. Yes.
Healthcare providers.
Pharmacists, yes. And
when we talk about healthcare providers, they include physicians, pharmacists, nurses who are in contact with patients.
Okay. So we've got a few. So we've got donors, you've got industry, you've got the local regulatory authority, you've got managers of public health programs, you've got media, you've got consumers, so the patients, you've got the WHO supports member states in initiating, organizing, guiding and implementing. You've got other international organizations, you've got Ministry of Health, the public, healthcare professionals, community health workers and researchers. Because also, when you say healthcare professionals, you also have, when you have a setting where you have mass drug distribution, the people who are giving the medicines are not actually healthcare professionals. There might be people who are trained to give a certain medicine, and they could be teachers, they could be, but they work in the community to distribute the medicines. So there are a lot of people involved. And then, so these are just some public health programs that we have, and then it goes through a hierarchy. So you have the international, and at the international level, then you have the national level, where you have the Minister of Health, and then you have the healthcare worker, and then it goes down to the patient. Okay, so how do we actually integrate? So can anyone give an example of how if they have integrated the PV into a public health program in their country?
In Oman, we establish reporting for the public by portal online. The public, customer or patients can reporting for ADRs by the portal of Ministry of Health. Okay,
that's a tool of a method of reporting. Yes. Okay, but has anyone worked with the National Centre has worked with a disease program like HIV or TB, and how did they manage to work together? Satha.
Actually, in Sudan, we have a collaboration between the National BV Center and HIV program. So we have like a pilot phase in starting an active surveillance for HIV medication, but actually due to financial problem, we couldn't go further than the pilot state. And then we have targeted in malaria program and TB program for spontaneous reporting. And now we are trying to establish an active surveillance for second line anti-tuberculosis, but that will maybe launch soon in Sudan.
Okay. Okay, that's great. Okay, so how do we integrate? So basically, you need to know your public health programs. So you need to know what public health programs you have in the country. You need to know your PV, for people who are not from national centres here, to know who your PV focal person is. You need to have the network. You need to make sure that if there is a workshop, for example, seasonal malaria chemoprevention, they usually have a workshop for community workers on how to record like surveillance of giving out the medicines and so on, to put PV into that workshop. You know, they have a training session anyway to make sure PV is in the training sessions. To get involved in mass drug distribution campaigns. For example, in Sierra Leone, you have a PV supervisor who will actually go on site when they're doing mass drug distribution, when they're actually giving out the medicines. There is a PV supervisor who will be there, and people who know who they are, and then people then trust what's going on because they know that the safety of this medicine is being monitored, or these medicines are being monitored. And also to build awareness and sensitization. So often before a campaign starts, in some countries they use radio, they use all sorts of media methods to build awareness of the campaign. So to have to put PV into that sensitization and awareness exercise. Okay, so then moving on to the pharmacovigilance methods used. Okay. Oh no. Sorry. Okay. So so we have the routine surveillance, spontaneous reporting, and then we have the active. So we have targeted reporting and cohort event monitoring. Okay, so spontaneous reporting systems. So that's the bedrock of the program. That's how everything started, and that will continue. And you have a cohort event monitoring. So this is more intensive. So it's a prospective observational cohort study of adverse events. So you're intensively monitoring patients for adverse events for a small period of time until you build up enough information. And then you have the targeted spontaneous reporting, which is applied in a defined setting. And then also you have intensive monitoring. Some countries, for example, some people may have within a hospital, they look at hospital admissions and they intensively monitor to see if it's due to an ADR, and they follow up that patient, and then they have intensive monitoring. So the benefits and challenges of having routine monitoring, so spontaneous reports. So they're low in cost, they're not as costly, they're routine. They detect rare or serious events. They detect long-term adverse effects, so things that that could happen over a period of time. It covers all medicines, and anyone can report. Can anyone think of the challenges of having routines or spontaneous reports? What's the disadvantages of them?
That particular medication, one of the important challenges in spontaneous reporting is about the bias they have there, because you wouldn't know this particular adverse drug reaction is because of this particular medication, because there will be on many other medications. And always, because we look into pregnancy medications and a lot of surveillance and spontaneous reporting, so we feel that it's not been always a true picture of the whole thing what they take. So that's one of the backdraw. I mean, you can challenges in spontaneous reporting.
Okay. That's always.
I guess data quality and also lack of follow-up information.
Yes. Yeah.
And quality is referring to either medically confirmed cases or non-medically confirmed cases, and then also that I guess there is a lot of missing values always.
Okay.
Or often.
Okay. Okay, so let's see what I've got here. So you have the under-reporting. Okay, so the actual number of adverse drug reactions may not be completely representative. It can be subject to bias. So you can have, for example, a media cover something happening in the media, and then everyone's all of a sudden reporting. There's generally no denominator because you don't know the usage of the drug. But however, when you do have, say, a public health program has mass distribution, they have a record of how much of the medicine's been given out. So that's, but you can't calculate a rate. It's not good for intensive monitoring, and deaths are very poorly reported. So cohort event monitoring. So it's a prospective, observational cohort study of adverse events associated with one or more monitored medicines. So I have a definition here of what an adverse event is and what the report is. It's not intended to replace spontaneous reports. It's supposed to be, you're supposed to still continue spontaneous reports. It's very time limited, and it provides timely and high quality data. And targeted spontaneous reports, so it's a method to better characterize a previously defined adverse drug reaction. So you kind of know what you're looking for, but you want to find out more about it. And better understand a risk group and disposing factors. And it's within a defined cohort. An example of patients receiving tenofovir may be monitored for renal toxicity. So the benefits of spontaneous reporting, of targeted spontaneous reporting. It's simple. It's less labor intensive than cohort event monitoring. It uses same reporting channels as spontaneous reporting, so using the same form. Sometimes with cohort event monitoring, because you want to gather more information, you're using a different form, gathering more. It uses existing PV systems within the country, and it focuses on priority ADRs. Limitations, again, is the same as underreporting. Okay, so this is the WHO strategy. This is the diagram we saw earlier for integrating PV and public health programs. So you would have a spontaneous reporting all the way through. Initially, when a new regimen or a new product is introduced, you have the cohort event monitoring. So that will find out the most common adverse drug reactions, because normally you would do it for the first 3,000 patients. And if there's anything alarming, you would find it straight away. And then you'd have the targeted. So you might find, okay, this drug may cause cardiovascular events, but I want to look into this a little bit further. So you just look at the cardiovascular events that happen with this drug, and then that's what happens throughout the product life. And then this is a slide from a study which has been updated, but I haven't got the results yet. It's carried out by the WHO Collaborating Center in Rabat, where they did a survey of 55 countries to find out the challenges that remain from introducing PV into low middle income countries, which would also be the challenges that you find also in public health programs. And the top ones are lack of resources, political support. I don't know if you are familiar with these challenges. Lack of competence, so people need training, lack of PV systems, or inadequate function, and lack of communication information exchange. But this was done quite a few years back. There is an update, but I haven't got the results for it yet, so we don't know if these problems are still existing, or if there are new problems, or they've been resolved.
Okay, you don't have any more questions, so we can thank you, Noha, for your intervention. Thanks a lot for all the information. And we also would like to give you this gift from UMC.
Oh, thank you very much.
You're welcome.